Hello, everybody, and a really warm welcome to this event, which is called Ask the Experts, Living with Incurable Ovarian Cancer and Accessing Palliative Care Services. I'm Lizzie Hussain. I'm Deputy Director of Services at Target Ovarian Cancer, and I'd like to welcome Adrienne Betteley, Strategic Advisor for End of Life Care at Macmillan, who will be delivering this session and asking your questions. So today's session is covering the topics of living with incurable ovarian cancer and palliative care, and we'll be hearing from Adrienne about the services and support available, as well as terminology that's commonly used. And following that, there'll be a chance to have your questions answered by Adrienne in our live question and answer session. So we understand that this is a really sensitive topic that we're going to be talking through today, but we just want to reassure you that this event is a safe space to discuss that topic, and there's support available should you need it. So I'll ask Adrienne to introduce herself in a moment, but before that, I'm just going to take a couple of minutes to run you through some practicalities. So some of you might have attended our Ask the Expert sessions before, and this event will take a similar format to that, but it might feel a little bit different to usual. So we know that this topic can potentially be upsetting. It can be difficult to talk about. As I said, we just want to make this a really safe space for everybody joining today. But if you find anything that we talk about upsetting, please do feel free to take some time away from the session, and rest assured that we are here to support you if there's anything that you'd like to follow up one-on-one. And I'll give you details about our support line where you can do that a little bit later on. And before we start, I'd just like to ask you to remember that everybody here has really different circumstances and situations. And please remember that about yourself as well. So things that you hear might be relevant to you, but they might also not be relevant at this time or at all. And everyone's at different stages and they have different circumstances. Everyone's coping differently. So just keep that in mind and respect everybody's views and concerns. Just because we want to make sure that this session is a safe and positive space for everybody who takes part. Adrienne will be covering a number of topics today, but I just ask you to remember she isn't a specialist in ovarian cancer specifically, ovarian cancer treatment. So if this session raises any ovarian cancer specific questions that we can't answer today, again, our support line is the best place for you to go to ask those one-on-one questions after the session. It might be that we don't have the opportunity to answer everybody's questions today. But again, if your question doesn't make it to be asked, the support line is a great way to ask that question and get some feedback. So just a few more disclaimers before we get started. So anything that comes out of this session isn't kind of medical or legal advice. It isn't a substitute for the information and advice you'll be given by your own clinical team. And we're not able to offer answers to very specific individual situations today or symptom management questions. But the idea of this session is that we just give you a really good overview for any conversations that you'd like to have with your own team. If anything comes up today that you're not sure about what it means for you, then please do call the support line, and the support line number will be added to the chat. And as I said, please do take a break if you need to. So we're going to begin the event now, starting with a presentation from Adrienne. So I guess it's over to you, Adrienne.
Hello, thank you. And thank you so much to everybody at Ovarian Cancer, Target Ovarian Cancer, for inviting me. And thank you to those of you who are joining live today and for anybody that's watching after the event. Hopefully, I'll be able to give you a little bit of a flavour around palliative care and end-of-life care, what those terms mean, and where you might be able to access some support. And as Lizzie said, I'm not a specialist, and I'm not a specialist palliative care nurse either. So my background is nursing, but I predominantly was a district nursing sister and have supported many people over the years with palliative care needs and end-of-life care needs. So if you could move on to the next slide, please. Sorry for sounding like a politician. With the next slide, please. So this is just a general definition that comes from the World Health Organization. So it just articulates what palliative care is. I'm not going to read it word for word, but basically palliative care is very much an approach. So it is about improving quality of life. And I think often you might hear professionals referring to somebody as being palliative. I don't really like that, because I think it is about the approach. Palliative care is a holistic approach. So it's about you being seen as an individual, looking at all of your needs, not just the fact that you've got a cancer, but actually it's about your spirituality, it's about your emotional needs, financial needs, and all of those aspects which are really important to you. And actually, we found over the years that the earlier people receive palliative care, then the better their quality of life. I'm going to talk a little bit more about what sorts of palliative care you can receive and from whom, but it does involve a range of professionals, and those are just a flavour of who might be supporting people with palliative care needs. If you can move on to the next slide, please. So I think even in the professional world of healthcare, people often get confused with terminology, and there is lots of different terminology, which is not always helpful. So another term that can be used, and I'm putting this in because there are different terms that are used in different areas. There's not always an exact same approach wherever you live, and that might be different in different areas of the UK, and it might be different in different regions of those countries within the UK. So supportive care is a term that's come more recently, and that's been a way of developing services mainly through cancer centres. So cancer centres such as the Christie Hospital in Manchester or Clatterbridge on the Wirral. So supportive care is about the prevention and management of the adverse effects of cancer and its treatment. And again, quite similar to palliative care, and actually often people can be receiving supportive care from cancer treatment and actually as well receiving specialist palliative care. Could we move on to the next slide, please? So end-of-life care. So this definition comes from the General Medical Council. This is basically anybody who might be in the last year of life or thereabouts can expect to receive end-of-life care. And it can be for people with advancing progressive incurable conditions. It can be for people with general frailty and coexisting conditions. It can be people who are at risk of dying from a sudden acute crisis in their life-threatening acute conditions. And it could be somebody whose death is imminent, that could be expected within hours or days. If you could move on to the next slide, please. So what palliative and end-of-life care support can I access from health and care services in my area? Well, as I said, it isn't a standardised approach, unfortunately, which would have been a lot more helpful if we could know what to expect in every single area. But the one thing that you can expect is that there are GPs, and GPs should be absolutely fundamental in getting to know you and getting to know your health, your cancer, what your wishes and preferences are. District nurses can be really fundamental in supporting people who have palliative and end-of-life care needs. And if people are living in care homes, then care home staff can provide some support, and also social services depending on people's circumstances. And though we in the healthcare world call that generalist services, and then the specialist services are things like specialist palliative care nurses, specialist palliative care occupational therapists or physios, dietitians, hospices. Hospices are absolutely fundamental in providing palliative care, particularly specialist palliative care for people with complex needs. Unfortunately, not every area has a hospice, but in the main there are hospices, although they have limited provision. But it's really worth finding out about local hospice and what they provide. Some provide some respite care and some provide outreach services as well. And I know from personal experience, when I was going through my second cancer treatment last year, I was actually referred by my specialist cancer nurse to my local hospice for reflexology, for aromatherapy massage, and I had hypnotherapy and acupuncture. And those were amazing in providing me with that kind of particularly emotional, psychological, spiritual support that I needed. And then there are things like hospice at home. Marie Curie also provides some really fantastic services. They sometimes provide, say, overnight support from a nurse or a healthcare assistant. And again, it's worth asking your GP or your district nurse or your specialist nurse, your cancer nurse, what services are available and what you can access in your local area. A more relatively new thing that seems to be happening across the UK is something called compassionate communities. And this is very much about grassroots, people in communities who are there to support people. Compassionate communities are often services that are developed by local hospices, and it's about providing almost like an army of people who are there to support those people who have palliative and end-of-life care needs. And it may be for companionship for those who are living alone. It may be for things like, helping with shopping, taking to appointments, all sorts of things, but really fantastic schemes. And there are some brilliant volunteering schemes in local areas, but again, each area will have different provision. And end-of-life doulas is a growing movement. So this, in a sense, is a bit like having a midwife who helps you with bringing your baby into the world. An end-of-life doula, otherwise also known as a soul midwife. These are people who are trained and are there to support people at the very end of their life and as they die, and to support the families around them. And there's a really good website, actually, End of Life Doulas UK, where you can find out what's available in your local area. Next slide, please. So why is it important to plan ahead, and the importance of early conversations? Well, planning ahead can be really hard, but it can help if you talk to your healthcare team, family, or friends about what matters to you. It can help everyone to understand the care, the treatment, and the support that you want for your future. And it can also be a way that people find of taking back control around their health and their life, especially when if you're living with uncertainty. And who needs to know what? Well, I think it's really important to speak, particularly if you can, to your loved ones, and as soon as possible, really to think about what it is, what are your preferences, what are your wishes. Not everybody has a loved one, but it may be somebody that's a neighbour or a friend or a work colleague. So involving other people who know you to understand what it is that's important to you. And also talking to children, if you have children, and thinking about what it is that you want for the end of your life, thinking about all sorts of things, practical matters. And then when you think about health professionals, they also need to know what your preferences and wishes are. They want to know what you want for your treatments, whether you want, what sort of types of pain relief you might want, where you want to be cared for. There's a whole raft of things that are really important to talk about, but I would urge people to talk to their healthcare professionals who are involved in their care. And next slide, please. So thinking about difficult conversations, especially if you are living with incurable cancer, that can be really hard to think about, and it can be really hard for those around you. So I put just a few things here that I thought might really help. So there is something about being prepared for a conversation, making a plan for that conversation, thinking about the environment. Where would you be comfortable having a conversation with somebody that you want to talk to about your palliative and end-of-life care needs, about your preferences and wishes, somewhere that's safe, comfortable and easy to talk. And it can actually help to give somebody a warning shot rather than just launch into a conversation. If they're not prepared, it can come as a shock and they've not had time to gather their own thoughts. So if you are able to just perhaps say something like, I'd really like to talk about where I'm up to with my cancer, what's happening for the future. Can we sit down at the weekend and talk about it, or can we talk about it later on? But actually, the sooner that you do start those conversations, the better, because it's not a one-off conversation. It needs to happen over and over again. But acknowledging, I'm saying it needs to happen, but not everybody can have those conversations. It can be really difficult. And if you're really struggling with that, I would urge you to either speak to your health professional or phone Target Ovarian Cancer support line or phone Macmillan Cancer support line and ask for some advice and some help about having those conversations, because it is really difficult. And it is really important to talk about your wishes and preferences. The more you talk about what you want, the more likely those things are to happen. So you also, if you're having a conversation with someone, such as a partner, then it's really important to check in on how they're feeling and what they want to know, to be able to really have a good conversation. And it's important to try to write down the preferences and wishes, and we're going to come on to talk a little bit about advanced care planning shortly. So next slide, please. So having a conversation with children, this is probably one of the most difficult things that anybody would have to do. And it is so hard, and I cannot imagine, I've not been in that situation myself, I cannot imagine how difficult it is. But I really would urge people to ask for some support, whether it's to have a healthcare professional with you when you're having the conversation, or whether it's about asking them about ways that they can give you some advice around doing that. But I think for children, it's worth thinking about the importance of being open and honest, and thinking about the impact about if you don't talk to them about what is happening with your health and your cancer and where things are heading, then that can be more challenging later on. And it's also worth considering the age of children, because it is very dependent on age. So here are some helpful things that you can think about when having those conversations. So it really is about trying to understand what they know and explain anything that they may have misunderstood. It's about using simple and clear language and short sentences, and keep information relevant to the current situation rather than the things that may or may not happen. Be prepared for them to react in their own way and ask them if there is anything else that they want to know. Explain how their lives and routines might be affected. And I think particularly for younger children, it is about repeating that information, especially for children under the age of 7. But again, I really would reiterate, please do seek help and support. And actually there's some amazing services out there, other charities that can provide specific support, such as hospices may be able to provide family support. There might be things like counselling support, particularly for children, that you can access. But the earlier the conversations, the better, in the sense that people are prepared, those people around you, particularly children. And as I've said, it's about going back to have further conversations and revisiting what they actually understand and acknowledging how difficult it is for them. Next slide, please. So, sorting out practical and financial matters. This is so important. There are so many aspects to deal with, and it must feel really overwhelming if you've not already got these things in place. I've tried to preach, I've tried to practice what I preach, should I say, and have got lots of things written down. I have made a will. I have planned my funeral. I remember very distinctly when my mum was dying, we thought we'd got everything in place. She got a lasting power of attorney. She had advanced care plans written down. She'd had all the conversations. We'd sorted all the paperwork out. And we'd even done a prepaid funeral plan. And she had a bucket list and, fulfilled as many things as were possible. And it was only really at the very last minute when we got to actually planning the funeral with the funeral director, and we realised we hadn't got a clue what songs she would have liked because she wasn't really very musical. And it's some of those kind of finer detail things that you don't always think about, but actually it made me feel really distressed at the time, because I thought, I want to get everything right for my mum. It's my mum. She was so special to me. So I think there's a lot to think about, so much about. But some of the really fundamental things that are important are about advanced care planning, or that's also known in Scotland as future care planning. And that's a way of literally writing down all of your preferences and wishes, what's important to you, where you want to be cared for, who you want to be with you at the end of your life. It's not a legally binding document. There are some legally binding things that people can access. So there are things like, in England, advanced decisions to refuse treatment, which needs to be done with your clinician. And that is something where you can say, in the event of X happening, I don't want certain things to happen, and it's all documented it's very specific and very clearly written down, but that does need to be done with your health and care team. So another part of advanced care planning, and particularly the legislation is quite different in the 4 nations of the UK, so please do have a look on government websites around things like lasting power of attorney, mental capacity act, because there are so many nuances around that. Or you can go to Macmillan Cancer Support's website, and we do list all the different legislation and what's important for people. But when it comes to making decisions, it's really important that if you lose capacity to make decisions on your own behalf, that you identify somebody to do that. And where there is a way to do that legally, such as under the Mental Capacity Act in England, you can appoint a lasting power of attorney both for health and welfare and financial matters. So you need to have 2 distinct ones for that, but that can be really helpful. And particularly things like, you have to register those with your bank and make sure that you have all your house in order. It makes it so much easier for those who are trying to support you if you haven't got the capacity to do it. paperwork and online accounts. I think nowadays we all live in such a kind of social media society. There are so many things that people access, Twitter and Facebook, things like that. And actually, it's really important to think about what do you want to happen to those if you're not around anymore, once you die. Who do you want to have access? Do you want to have them closed down? Do you want to create some sort of legacy? They're really important things to think about. I'm going to link additional financial matters and benefits and grants. Those are obviously things that are really important to people. It can be a really tricky time, particularly if you've had to give up work. There are so many ways that you can get support. There are so many benefits, but it is a complex system. So again, I would urge people to speak to their health and care professionals, or to go to Target Ovarian Cancer's website, or speak to advisors or to Macmillan Cancer Support, because there are lots of ways around things that people can help you. And making a will, I think I've already touched on, and funeral planning. Bucket lists. I know when my mum was dying, we had a very long bucket list. It included all sorts of things, and she managed so many of them. Things like a trip to Anglesey, things like spending time with grandchildren, all of those sorts of things. And recordings for a loved one. This is something that I think can be very precious. I know when my grandmother was dying, we wrote down lots of things about her life and her history, and I used that to go back and reflect on, and found it really just very inspiring. So they're all lots of things to think about, really important, but all really difficult, I guess. Next slide, please. So maintaining quality of life, and I think this is quite linked to maintaining hope. And sometimes, if you're in a situation where you're living with an incurable cancer, you're trying to find that balance between maintaining hope for new treatments to come along, different ways that you can get support, things to extend your life, as well as that kind of maintaining, kind of a balance and preparing for the worst. So a really challenging time. But maintaining quality of life can be really helpful. And actually physical activity, it can be challenging, particularly if you're experiencing fatigue. And I know when I was having my radiotherapy last year, I have never known anything like the fatigue that I felt. I wasn't expecting it at all. I think it was that in a combination of hormone therapy. I remember my daughter saying to me, "How are you feeling, Mum?" And I said, "I feel really fatigued." And she said, "Oh, I do too." And I thought, you really don't know what it's like to feel fatigued. In the same way that I don't know what all of you who are watching are feeling, but there can be real benefits in trying to do physical activity, but in a planned way, because actually maintaining a really good, healthy balance and good quality of life is really important. So having a good, healthy diet if you can, and if you choose to, trying to do the things that you enjoy in life. If you like walking, if you like reading, singing, whatever those things are, they can be really helpful in keeping that balance. And actually physical activity can help with fatigue, but you'd need to do it in a very planned way, speaking to a healthcare professional such as a physiotherapist. And what you need to really think about is pacing. Try to set goals about what's achievable. What's your normal at the moment, as in what can you achieve, and don't overdo it. I remember thinking at one point when I was really suffering with fatigue, I'm going to beat this, I'm going to go and do my usual swim, I'm going to do some exercise, and then completely exhausted myself. And my radiotherapist had to have a very stern word with me about actually keeping that balance and not overdoing it. So let your body tell you what it needs. And I think a lot of people want to keep on working, and that can be really difficult, can't it? And I guess it's about being able to have good conversations with employers. Different employers are, some are great about flexible working, some are great about time off. But again, speak to your healthcare professional about what other support you can get. Emotional well-being, I think that's one of the most difficult, one of the most challenging things for anybody living with cancer. It's so difficult to keep positive. It can really get you ground down, but there are so many ways that are really helpful. So I mentioned before about having, personally, this help for me, radiotherapy, after my radiotherapy, was having reflexology, complementary therapies, talking therapies. There are so many sources of support. And again, speak to your healthcare professional. There can be counselling and support that you can access, psychological therapy, group therapies. People often find, I'm still in a WhatsApp group from my ladies with breast cancer, and our peer support was one of the biggest things that I think really helped me. It's about being able to bounce ideas off each other and having shared experiences. And I'm sure through Target Ovarian Cancer that you have that kind of network of support. And also Macmillan Cancer Support has an online community for people who are living with incurable cancer, if you wanted to, or were interested in joining that. And spirituality, I think spirituality is something that, as a healthcare professional, I've observed other healthcare professionals often think it's religion, and that's it, spirituality. I've seen lots of forms filled in by health professionals on the box that says religion, that's Church of England or Jewish or whatever. But actually spirituality is so much more than religion. Religion is a part of it, but actually spirituality it's about what makes you tick, about your values and meaning of life, what's important to you. And I think, for people who are approaching the end of their lives, and for people who are having, experiences such as living with incurable cancer, that whole sense of purpose, you can feel quite questioned. And again, it's really good to be able to talk to people about that to help you work through all of the difficult situations that you're experiencing. And the same with relationships. It's really important to seek that support from healthcare professionals or contacting support lines, thinking about hospices, as I've already mentioned. Next slide, please. So I guess it's always important to remember that, it's very easy for me to sit here and say, you could try this, this might help. But actually, you are the expert on you, and it's what matters to you that is most important. And always remind yourself and others of that. Thank you. So we've just popped up our Macmillan Cancer Support line, which is open 7 days a week if anybody does want to phone to get that source of support. And on the next slide, it just shows what the different sources of support that you can access. So we've got energy advice, work support, welfare rights, Macmillan grants, financial guides, so lots of different sources of support. So please do reach out. So thank you so much for listening. I hope I've covered most things that people might want to have heard about. I look forward to the questions.
Thank you, Adrienne, for that really in-depth and very to the point presentation. So we're going to move into the question and answer portion of the session now. So I'm just going to begin by asking one of our kind of questions that were sent in advance. So somebody's asked us, is there a difference between palliative care and terminal cancer care? And when would we expect palliative care to start?
Yeah, so palliative care, as I've mentioned earlier on in my presentation, is about the approach. So sometimes people can access palliative care and they might have palliative care for years and years. And often it's around the needs of the person, not about necessarily the fact that they're in the very end stages. So if somebody has really complex needs, whether that's psychological, whether it's physical, pain and symptom management, whether it's, emotional, having difficult conversations, should be able to access palliative care. And actually, the earlier that you access palliative care, the better, because it really does improve quality of life and helps people to prepare for what is the inevitable and to have plans in place. So they're quite intertwined, really, I guess. I don't really like the term terminal, if I'm honest, but it's very individual, isn't it?
Yeah, so we've got a question. It's funny that you say that you don't like that terminology, because we've kind of got a question about terminology here. So somebody said the connotations of the word palliative can cause panic in people when it's first discussed with them. Are there ways in which you believe these services can be introduced to people in a way that doesn't have them automatically thinking that the Grim Reaper is standing at the end of the bed, and instead more effectively summarises what the service means?
Yeah, and I would hope that if people have support from a clinical nurse specialist, that when they talk about referring to, for instance, a specialist palliative care nurse or a specialist palliative care team, that they would actually explain what palliative means and the fact that it is an approach, it's a holistic approach, and that it doesn't conjure up images of the Grim Reaper. I think it's almost a bit of a societal thing, isn't it, really? So I know my first experience of somebody dying was when I was a child, and my best friend died from leukemia, and I wasn't allowed to go to the funeral. We didn't talk about it, and I had nightmares. And I think in society we don't talk about death and dying, and so therefore it makes it more challenging when somebody, you know, is approaching the end of their life, because nobody wants to talk about it. I remember when my grandmother was dying in a hospice, I couldn't actually go and visit her in the hospice because I had this image of it being, you know, people wailing in pain and awful and dark and candles. And then when I was a student nurse many years later, I spent quite a lot of time in the hospice, and my local hospice, and it was just amazing. It was a place of hope, of joy, obviously sadness for some people at certain times, but actually that the whole ethos of palliative care and hospice is about positivity. It's about living your best life. And that's what we need to hold on to. It isn't negative. It isn't about the Grim Reaper. You know, I think that's an important one for me. And I think in society, we need to try to shift to being more open and honest and not conjure up those awful images, because that is not what death is like.
Thank you. So we've had a few questions about kind of timing. And somebody's asked, at what point would you expect to be offered a referral to a palliative care team? And they've provided a little bit of background and said, both my GP and oncologist only want to refer me if I'm having symptoms such as pain. But as there's no further treatment on offer to me, except perhaps a trial, I think I should be referred for support.
And I would agree. I think you should be referred for support, because as I've said, the earlier the better. I guess the complexity is, at the moment, things are quite difficult in the NHS. Services are really tight. And actually specialist palliative care teams are quite limited and sometimes can only see people with complex needs. However, I do think that there are other ways of accessing palliative care, whether it's through your local hospice or your GP could refer you. And I think then once you get into that system, into the palliative care system, then you'll be much easier, or it will be much easier, accessing that support. But I would definitely ask to be referred for palliative care support, because it's absolutely fundamental, particularly if you've been told that there's no more treatment, because it's not that there's no more support. There is support out there, and it's very much needed.
So asking a direct question to your GP, for example, might
yes, absolutely. Or even ask, you know, can you refer to your community nursing team, and they can come out and do an assessment, and they may be able to refer you. Each area has different services, and they sometimes have different referrals. So I can't necessarily answer very specific questions. I just saw something pop up then about whether you can self-refer. There may be, in some areas, you may be able to self-refer. I know in my local area, you couldn't self-refer to hospice. I had to get my clinical nurse specialist at the cancer centre at the Christie where I attended to do that referral to my local hospice. But there are always ways in.
Great. So we've actually had a question specifically related to hospice care and timing. So someone said, at what stage of end of life is hospice care invoked, and by whom? So I guess that's a question about access as well, isn't it?
Yeah, so I mean, I've touched on hospice a little bit, and like I said, there are, you know, most hospices are not NHS hospices. They are independent, you know, they're reliant on fundraised incomes. My local hospice, for instance, has only got about 10 beds. So they are quite a limited resource, and there can be waiting lists. But some hospices do provide outreach support, they do provide daycare, they provide various different therapies. And they do, you know, I was on a curative pathway. I'm on 5 years follow-up, and I've been to my local hospice and had that support. So hospices are not about end of life. They do a whole range of support for people who have complex needs. And, you know, if you're living with an incurable cancer, then you inevitably will have complexity around that, whether it's difficulty sleeping, whether it's problems about work, whether it's relationships, whether it's symptom control. You know, there's a whole raft of needs that hospices can help you with. So please don't think it's at the very end of life. There's no definitive timeline as to when you should be referred to a hospice. People think it's just about, going, not just about, that sounds awful. People think it is about going to a hospice to die and nothing else, and that really isn't the case. People sometimes go in for symptom control for a couple of weeks if things are really complex, and then go back to home or to a care home or wherever they live. And they provide all sorts of support.
Great, thank you. And we've had some question about coordination of care as well. So somebody's asked, how best can you get the hospice community nurses and your oncology team to work together for your care? It's frustrating when no one entity will decide and yet they don't communicate between themselves.
Yes, and that was one of the pre-posed questions that I have to say I've probably found one of the most challenging questions, because that can be quite a common problem. Some areas have brilliant services where they have care coordination, they have a central hub that's a point of access and everybody knows. I'm very fortunate in my local area. I know that we have brilliant IT systems that actually speak to each other. So the tech is great. You can actually access from somebody's home, looking at hospital records and things like that. Unfortunately, that's not always the case. So it can be really challenging. I guess it's about asking your specialist nurse, who is my central point of contact? Who is my coordinator? Who can how can you make sure my information is transferred across to the relevant health professionals, and sort of holding them to account, really. And if that's not happening, then I would go to local service providers and say that, you want to complain. It's not good enough, really, because it's really challenging having to repeat your information over and over again. That's so difficult, isn't it? You just want everybody to know exactly everything about you, about your health, your conditions, what's important to you, rather than telling your story endless times. That can be really grinding.
Thank you. So we've had a couple of questions through now specifically about death, dying and end of life. So the first one is, as places like Dignitas aren't always an option for most of us, can you tell us what dying would be like? Will we be sedated? Will we understand what will be going on? What kind of pain will we feel? What will it look like for our family watching us die? And this person mentioned that they have young children, so they're worried about that aspect of them seeing the process.
Yeah, thank you for that question. So I think, again, going back to the point I was making about dying being very much a taboo in our society, we don't talk about it. And I think the only time we really tend to see stuff around dying is, in the media, and it's all very dramatic, and can be catastrophized in some ways. And I have to say, my experience of supporting lots of people for many years who've been in the dying phase, it really isn't like that at all. And there's an absolutely beautiful video that I don't think I could articulate it in such an amazing way as she has done, but there's a consultant in palliative medicine called Catherine Mannix, who's produced a video that's called Dying for Beginners. Well, it's an animated voiceover. So I think we're going to be able to put that hopefully in the chat for people if you do want to watch that. And Catherine really demystifies dying and the process and talks about the different stages and the phases that people go through. But it really is much more of a kind of gentle process than people imagine. It's a gradual process usually where people start to go out less, start to feel a bit more weary, don't want to eat as much. And in my experience, mostly when people die, they drift in and out of consciousness. The last thing to go is your hearing. So people find it, that people really benefit from having somebody perhaps holding their hand and talking to them as they're actually in that dying phase. And I know when my mum died, she died at home. We were very fortunate, had lots of support, and I was with her holding her hand, and her last words to me were, "Thank you, Adrienne, for being there for me. You've been a wonderful daughter." And she said the same to my dad, and it was a very beautiful experience. So the more things that you can put in place to plan for the end of your life and for your dying, the better. It's so difficult with children, and not everybody wants their child to experience that. And I think, yourself, your child best. But again, I would think about having conversations with palliative care team about what that might look like and what's best for you. But please do watch, if you feel like it, please do watch Catherine's video, because she does really describe it in a very beautiful way that's very reassuring and very calming. And that's what my experiences have been of supporting people. And there are plenty of medications and things that, you know, there is something called a syringe driver that's usually used when somebody's in the dying phase, and that makes sure that the drugs that you potentially will need are getting into your system so that they prevent pain, they prevent any agitation, and you are gradually sedated into that gentle sleep.
Thank you. I think that kind of covers our next question. So someone's just said, I'm worried about the end days and how to get pain relief and comfort as I reach the end of the struggle. So is there anything else you'd like to add on that, or do you think we've covered?
I think we've covered it, and you know, if you're getting that support from either hospital staff or community staff, then and you've got somebody else that's with you, you know, they know the person best and they can ask for some additional pain relief. So whilst you might have the syringe driver, the pump that I talked about that just sends the drugs under the top layer of your skin, sometimes you might need a bit of a top-up drug, another injection or other medication, and they will be able to do that to make sure that you are pain-free.
And are there any books? Obviously, you've already recommended that video. Are there any books or any other resources that you would particularly recommend on the topic of end of life?
Yeah, so I mean, I think I must be on commission for Catherine Mannix if she's watching at a later date. So she's written a really beautiful book, I think, called With the End in Mind, which again is, you know, talking about end of life care and sort of her experiences as a doctor as having supported people. But again, there's some really, we've got lots of resources on our Macmillan Cancer Support website around living with advanced cancer. And about all the things that, you know, you need to think about and prepare for and what to expect. And, you know, Marie Curie and others have got some, and Hospice UK have got some really good resources.
Great, thank you. So I've just seen another question come through in the chat on this topic. So somebody's asked, give me 1 second to pull that up. Do you always need to be medicated when you die of ovarian cancer?
So from a technical point of view, I guess there's no, you don't need. Well, you may need, you may choose not to. I suppose that's the point. Maybe I'm not sure what it is exactly the person's asking. You know, if you're suffering with symptoms, then most people would want to have those symptoms controlled. But there is sometimes a fine balance, and I can't talk specifically from ovarian cancer, but sometimes there's a fine balance where people don't want to be too sedated, that they're not aware of what's happening, and they want to have those conversations, and they want to participate in daily living as much as and as long as they can. So some people choose to have that kind of balance between, okay, well, I can perhaps tolerate a certain amount of pain or, you know, other symptoms, and for the benefit of being able to have those conversations and appreciate those last moments of life. So that should very much be your choice. And that's where it comes into the conversations that are so important about advanced care planning and writing down your preferences and wishes and talking about that really early and planning for the end.
Great, thank you. So we're going to move on to some questions about planning. So we've touched on this earlier in your presentation, and you mentioned lasting power of attorney. Someone's asked a question around that. So having a lasting power of attorney around health and well-being is not enough, it appears. What document or documents do you need to complete for the hospital to listen to your wishes?
So a lasting power of attorney, just to be clear, so I mentioned before, and this is relevant to England, so sorry I couldn't get into real specifics about the different nations and technicalities, but in England there are 2 types of lasting power of attorney. So there is one for health and welfare, and there's one for property and financial. And for the property and financial, it's really important that actually anything like your bank, you need to notify and register to make sure that if somebody has to go in and speak on your behalf, then they can do so. But when it comes to the health and welfare, and actually for both, sorry, with lasting power of attorney, it's really important to bear in mind, it can only be used if you lose capacity, because ultimately the health and care professionals should be speaking to you, should be asking what your wishes and preferences are. I mentioned very briefly before about things like advanced decision to refuse treatment, which is much more technical, much more medically focused. But at the end of the day, the doctors and nurses who are supporting you or any other health professionals, whilst you are still able to voice your preferences and wishes, then they should listen to you. So it's not a case of it shouldn't. You said, I think you said it's not enough. It should be enough, because it's about you and your choice. And if people are struggling with that, then go back to your healthcare professionals and ask them a bit more detail about what happens in local services. Or actually, if it's an issue for complaint, then if it's a hospital, then go to your patient advisory liaison service and make a complaint, because it is your health and your choice, and you should be able to make those decisions without being told what to do by health and care professionals.
Thank you. So you mentioned the ADRT, so the advanced decision to refuse treatment. We've had a question about what's the difference between that and a DNR, which I understand is a do not resuscitate.
Yeah, so do not attempt resuscitation orders are put in place when clinicians feel that it would be absolutely hopeless and do more harm than good to try to resuscitate somebody. So if their heart stopped or if they stopped breathing, and this should be done in consultation with the individual and also involving family members. But that is very specifically about not resuscitating, whereas advanced decisions could be about all sorts of different treatments and other things that you might want or not want in certain circumstances, but it is very specific.
Right. And kind of more a bit around terminology and when and how things are done. So somebody's asked, when and how is advanced care planning done?
So that's a really good question, and it can be done in so many different ways. And one thing I've not actually mentioned as well, which I should have mentioned, is around holistic needs assessment. So anybody going through cancer treatment, I would hope and anticipate that they would have a holistic needs assessment. It might be an electronic needs assessment that's undertaken, it might be with your health professional, but that's more generally about your needs and identifying what are the most important needs for you. So that might be around you're struggling with sleep or you're struggling with pain, but that can be a catalyst to then having a conversation about advanced care planning, because advanced care planning is much more about the sort of softer things in life, not so much about treatments and stuff, but actually about preferences, wishes, where you want to be cared for, what you want to happen to your cat, for instance, after you die, or all of those sorts of things, that whatever is important to you as an individual. So usually advanced care planning is led very often by specialist palliative care clinicians. When I was a district nursing sister, we used to use a form called Preferred Priorities for Care. I would have conversations with patients about what was important to them. And it depends who's confident to have that conversation. You can do it yourself. My dad filled one in many years ago. And I think he downloaded one from Age UK's website. As an older person, he could relate to that. So he completed that and said to me, right, you need to tell my GP and we need to put it here. And, so it was very much led by him. So it can be led by a professional, it can be led by you as an individual. Some areas have volunteers who do this with people. It's very different in different areas, but ask for it is what I would say. So ask somebody to have a conversation with you about advanced care planning and say that you want to fill in the paperwork and you want it shared with your GP and any other professionals who are supporting you.
Great, thank you. And we've just had a really interesting question from the chat. So someone's asked, when could you expect a holistic needs assessment to take place? And they've mentioned that they've never heard of it before.
That's a terrible shame that you've not heard of it. And I have to say, the first cancer I had, I got one about 2 years after my diagnosis when I was on a follow-up. Should have asked for it, knowing, as I know, I work for Macmillan Cancer Support, I wasn't overly concerned. And then my second cancer that I had was actually the therapeutic radiographer, who I wasn't expecting to do it, quite early on in my diagnosis, undertook the Macmillan Holistic Needs Assessment. So you can go on Macmillan's website and have a look at that particular information, and did a really comprehensive needs assessment. And that's actually when things came up about stuff I was struggling with, like sleep and anxiety and all sorts of different things. And therefore that can be the catalyst to putting in a plan of care and signposting to different services. So it's usually led by cancer services and less so by community services.
Thank you. And we might have covered this already, but I'd be interested to hear if you have any, you can recommend any resources or anybody specifically to talk to about this. So somebody's asked, how do you plan for your future financially and personally?
Yeah, that's quite a complex one, isn't it? Because financially it is just, there's so many things to think about. So I have touched on it slightly. I mean, you know, not everybody can afford a financial advisor, but getting your house in order is really important, isn't it? Because you want to think about what happens after you die. You want to make sure that you've got a will. You don't want to die intestate, because that can be really complex for whoever's sorting out your estate after your death. So I really would implore people to go to seek support, phone Macmillan Cancer Support telephone support line, because we have got amazing benefits advisors, welfare advisors, financial advisors who can really go through an in-depth assessment and really help, you know, save money on certain things, think about what grants might be able to be available and really help you with all of that. I'm not a financial expert, sorry.
No, that was great. Thank
From a
you.
personal perspective, I guess it is writing down plans and wishes, isn't it, that we've already talked about, really, and making sure that they're accessible to people, knowing what, so that everybody knows where they are if you're not around.
Great. And I'm just going to ask the final couple of questions now. So if anybody in the session does have a question, please pop it in the chat so we can see if we can address it before we finish up. But just another one of our pre-submitted questions. So you covered a little bit about talking to children specifically, but we've had a more general question of how can you tell your family?
Yeah, that's a really difficult one, isn't it? So I've had so many situations when I was a nurse, and you know, people really struggle to talk to each other. So often in family situations, everybody knows and nobody talks about it, and it creates this almost like tension between everybody, and it can make relationships really fraught when you're not talking about it. So I think it really is about trying to drop subtle hints, trying to give people a warning that you feel it's really important to talk about what's happening with you, with your cancer, and how you're feeling and what you want for the future. I can't say for individuals what's right or wrong or when to do it, but there are things that you can think about. And I did give some of those tips before about, you know, thinking about the environment, delivering the warning shot, checking in on what they know, because actually, you know, often people do know what's going on, they just don't want to talk about it. I remember a situation where I was going to visit a gentleman at home, and it was a first assessment visit. He'd got an incurable cancer, and before I even got to the gate, his wife came running out and she said to me, "Oh, don't talk about it. When you come in, don't talk about it." And you know, that was kind of the start of a really tricky relationship in trying to encourage them both to be open and talk about it. And we did involve specialist palliative care clinicians because they were having so many struggles with actually coming to terms with what was going on with him. But actually, once they'd had the open conversation, the difficult conversations, actually it really helped them to move on with their lives and to focus on the living. And the tension, you could almost feel the tension was lifted. I think the worst bit about having those difficult conversations is around the whole anticipation, the uncertainty, not knowing what to expect. But if you are struggling, then please do ask for input from specialist palliative care, because they're real experts in doing this and they're involved in these conversations all the time. Even if you don't want them to be in the conversation, you know, seek some support and some help and talk to them about how you're feeling.
Thank you. And I think that really, I've just seen a note in the chat from somebody who's mentioned that their contact has been about specifically medical issues and they haven't realised there are additional services. So I think that makes it's really reassuring to kind of hear that those are there. Thank you. So I think we're going to finish up now. We did receive a handful of questions that were a bit too specific for us to answer today. So some around how particularly ovarian cancer symptoms like ascites are managed in palliative care and dealing with side effects of treatment. I would really encourage the people who ask those questions to us to contact our support line. You'll see my colleagues Val and Rachel, if you could give us a wave, Val and Rachel. They were on our nurse-led support line and they're here to answer your questions if you have any. And so I just want to say a massive thank you to Adrienne for coming and talking to us today. That was an incredibly illuminating session. Yes, please do feel free to call our support line on 020-7923-5475 if you need us. So I'm sure you'll all join me in saying a massive thank you to Adrienne for sharing her experience with us today. And thank you so much, all of you, for joining us. And we hope you found this session supportive and informative. So on behalf of the Target Ovarian Cancer team, thank you for your time. And we hope to see you again really soon. Bye.
Thank you so much.
Thank you.